Ladies and gentlemen, welcome to EM Tupo. This channel is dedicated for people like you who want to learn about ICU and emergency care. And today's talk is about ABG. So let's get right into it. So everyone talks about ABG, but there is this video that I am trying to make is to simplify everything that is there in ABG. It's the total package from multiple books, multiple resources, and obviously my professors who have taught me for a good number of years. Now, before wasting any other time, let's go right into it and talk about what we mean by ABG. So, first, what is ABG? ABG is arterial blood sample, and VBG is venous blood sample. Yes? Now, is there a big difference between them? Yes, there is. The difference comes about whether you took a peripheral sample or you took a central sample. But let's not confuse each other. But remember these two things. ABG is arterial sample, VBG is venous sample. We all know venous is a deoxygenated blood. So it is more acidic. It is more, it has more of carbon dioxide basically rather than oxygen. That we know. And if you look at the bicarbonate doesn't really differ. Now, if you want to know advancedly how it changes, if you take a peripheral sample and a central sample, meaning from the central line, then there might be a slight difference. But that difference is only important depending on your case. So, for example, if I'm looking at a case of oxygenation, or ventilation problem, then I would want to do ABG. But if the case is like, let's say DKA or sepsis, where I want to know the bicarbs, how severe is my metabolic acidosis, I want to see the lactate if there is there in the ABG, that's when I'm going to do the VBG and not ABG, okay? Because remember, ABG is very painful and you don't want to hurt your patients unnecessarily. Okay? Now, the acid-base disorder has some normal values, and you all need to know that, okay? So pH is 7.35 to 7.45. That's one parameter of ABG. Another is oxygen, which is 80 to 100. And then there is the carbon dioxide, which is 35 to 45. And your bicarb, which is 22 to 26. Now this is the most famous equation that you need to learn. It's called the Henderson's equation. It's a reversible reaction between carbon dioxide plus water, which creates hydrogen ions and bicarbonate. And from these equations, we derive a lot of things. Now, first question to ask, before even wasting your time in reading that ABG, is to know whether it's valid or not. And there is a simple formula for that. To check the validity, you need to know this formula, which is hydrogen times bicarbonate from the ABG divided by the partial pressure of carbon dioxide. And if the value is 24, then you know your ABG is valid. The error is plus or minus 2, meaning that it's not just exactly 24, but 24 minus 2, which is 22, and 24 plus 2, which is 26. So in between that range, that means that this patient has a valid ABG. Now, how do you know the hydrogen ions? That's the question. There are tables over there in the internet. They are available everywhere. It's basically comparing your pH, so you know the pH from the ABG, to the number of hydrogen ions that you have. So let's take an example of this window here. You can look at 7.2 to 7.5. There is a very easy way of knowing your hydrogen ions, okay? How do you know the hydrogen ion? Is just take the last two digits of your, so you take the last two digits of your pH and minus it by 80 and you get your hydrogen ions if it's in between 7.2 to 7.5. But otherwise you might need to refer to the table in order to get the hydrogen ions. So you input the number of hydrogen ions. So for example, let's say my pH is 7.4. So 80 minus 40, that is 40. So you take 40 times your bicarb, which could be anything, okay, from the ABG, divided by your PCO2 from the ABG. And if the number is in between 22 to 26, then you know it's a valid ABG, after which you can progress to reading the ABG at the end of the day, okay? Now, the second step to understand is oxygenation. You first look at the oxygenation in ABG. Partial pressure of oxygen is 80 to 100. Okay? Less than 80 is mild hypoxemia, less than 70 is moderate hypoxemia, and anything less than 50 is severe hypoxemia. Another relationship which is very important, we tend to forget, because we are giving 100% of oxygen to a patient, and then when you do ABG, the partial pressure of oxygen is only 100. And you go like, oh, 80 to 100 is normal, so I'm okay, but you're not okay. The relationship goes like this, that the FiO2 times 5 equals to your partial pressure of oxygen. This is very important in ARDS situations as well. You want to know how much oxygenation is your cells getting. And in order for you to have an ideal amount of partial pressure of oxygen, FiO2 should be times 5. So for example, if you're giving 100% oxygen, your FiO2 should be around 500, or at least near that. So that's very important, and that will help you in your treatments. Another ratio that you need to remember is partial pressure of oxygen divided by FiO2 in decimal points. Remember decimal points, okay? A number less than 300 is a problem in the right clinical context. I say right clinical context because you need to know the definition of ARDS. And it is based on the Berlin's criteria. So you should read the Berlin's criteria. And once you suspect that, you need to do a partial pressure of oxygen divided by FiO2, because that's one of the criteria as well. So less than 300 is mild ARDS, less than 200 is moderate, and less than 100 is severe. Okay? Now, before we go ahead, I would like to talk about the AA gradient. And that will come up in the next slide. ABG. So, oxygen in the lungs versus the oxygen in the blood. That's simply that. If it's high, it means there is a lung pathology. If it's normal, low, does not really mean anything. But what it means when it's high is that there is a problem with the lungs. Many times we are dealing with a septic case, right? And we think the source is uro, and the patient is hyperventilating because of the sepsis. But with the AA gradient, you can tell whether it's a lung problem. And you might order even an X-ray and find out that it is hypostatic pneumonia in this case. Now the equation goes like atmospheric pressure, which is 760, and you minus by water pressure, which is 47, and ideally you have 713. So if you're living in a place like me, which is 0 sea level, our atmospheric pressure is 760. Yours might be different depending on the level of sea. So let's say you get 713 times the FiO2. Now it can be 0.21, it could be 0.5, depending on how much oxygen you are giving this patient, okay? Once you get that, minus your carbon dioxide level that you found in your ABG, minus, divide by 0.8, and that's what will give you the AA gradient in terms of the patient. Now you need to find out what is the AA gradient for an ideal patient. The ideal patient's AA gradient, like me and you take my age divided by 4 plus 4. That's if I'm off oxygen and I'm on room air. But if I'm on oxygen, then you have to add this equation, which is called 50. Let me just erase this first. So this is 50 with the FiO2 minus 0.21. So FiO2 should be in decimal points, minus the 0.21 times the 50. This will add the equation of oxygenation that you're giving to your patient, okay? Now, the A gradient simply tells you what? That there is a lung problem. So, understand this, and let's move forward to the next part. The next part is very simple. It's the CO2. Ventilation is determined by the CO2, right? The normal is 35 to 45. Anything less than 35, you're hyperventilating. Anything more than 45, you are hypoventilating. And this is very important in those cases like COPD. For example, if you want to know whether you need to give BiPAP or not, their CO2 will be rising and you will immediately know that this patient needs BiPAP, either at night if it's a chronic patient or even at that particular moment if it's an acute case. Okay? Now the first step in any interpretation of ABG is to understand how it works. Now this is where we go to acid-base status of the patient. Now the acid-base status is determined by a mnemonic called ROME, R-O-M-E. As you can see here, the mnemonic is respiratory is opposite and metabolic is equal. Now your pH, okay, will determine this. Okay? How would you know that this patient has a respiratory alkalosis? The pH will be high, okay? That means there is alkalemia. If pH is high, that is alkalemia. If pH is low, it's acidosis. Now what kind of acidosis is by looking at the pH and the CO2 in terms of respiratory and looking at the pH and bicarbonate if it's a metabolic case. So respiratory, if pH is high and CO2 is low, that's respiratory alkalosis. If pH is low and CO2 is high, that is acidosis, respiratory acidosis. If the pH is high and bicarbonate is high, look, they're going in the same direction. They're equal. So that's metabolic alkalosis. And if the pH is low and bicarb is low, that is a metabolic acidosis. Now many times you will see a case whereby both are present. Both are primary cases. So for example, you get a patient with pH low, okay, and CO2 high. But you have a bicarbonate which is also low. In this case, you say there is primary respiratory acidosis with a primary metabolic acidosis. So that is where you cannot say which one is primary. You might need to do compensation formulas, which we'll talk about, and then you can figure out, okay, which one is the dominant one if both are primary. Okay? Now, we go to the most easiest one. This is called the metabolic alkalosis. Metabolic alkalosis means pH is high and your bicarbonate is high. Your CO2 can be low or normal or high, doesn't matter. Metabolic alkalosis, pH is high and bicarbonate is high when you look at the ABG. Now, the formulas to consider here is twofold. What I prefer using, and it has given me accurate results, and it correlates with the clinical knowledge that I've had on bedside, is this one, which is called 0.1 to 1. 0.5 to 1 is a range, okay? And you times by the change in bicarb. This will give you a range of CO2, okay? So let's say your CO2 range can be, let's say, 30 to 40, okay? But in your ABG, it clearly shows that it's not 30 to 40. It's not in between 30 to 40 after this equation. That means the patient is not compensating. But if it's within the range, the patient is compensating. And the compensation of metabolic alkalosis is opposite, meaning if metabolic alkalosis is your problem, your compensation is respiratory acidosis. And if your problem is metabolic acidosis, your compensation is respiratory alkalosis. So acidosis is a compensation by alkalosis in either of the cases, okay? And you need to remember that. So in metabolic alkalosis, as your bicarb rises, your body will try to retain CO2 to make the blood more acidic so as to neutralize the equation, which is created here in this case, okay? So if you have more bicarb, bicarb will combine with hydrogen ions and create more CO2. And that's the compensation that you are trying to create in terms of metabolic alkalosis. Now, many people think it's so easy. This is the compensation, 0.5 to 1 times the change in bicarb. Whatever range you get, you compare it with your ABG, CO2 value. If it fits the range, compensated. If it doesn't fit the range, not compensated. Now, from the range, if it is, let's say, the range was 20 to 30, okay? If it was less than 20, that means there is additional respiratory alkalosis. If the range is more than 30, right? The CO2 is more than 30, meaning it's out of range. That is now respiratory acidosis. So there is additional respiratory acidosis. But if it fits the range, then it's compensating. Okay? Now, approach to metabolic alkalosis. Many people in our institution don't do urinary electrolytes, but they are very important in determining the cause of the metabolic alkalosis. There are several causes of metabolic alkalosis, as you can see here, okay? It could be that you are administering bicarbonates, okay? If you have given a lot of bicarbonate to a metabolic acidosis patient, they will go into metabolic alkalosis. Hypokalemia has a tendency of shifting your hydrogen ions, okay, inside the cell. When you have hypokalemia, hydrogen ions go inside the cell, and this will cause alkalosis rather than acidosis. GI loss, if you lose your hydrogen ions with whatever form, vomiting, cystic fibrosis, laxative abuse can make you lose a lot of hydrogen ions, so then you can get metabolic alkalosis. In terms of renal losses as well, extracellular volume depletion, diuretic therapy. This is very common in heart failure patients. After 2-3 days, you will see they're in metabolic alkalosis because of diuretics. You are losing a lot of potassium, and at the same time, you're losing a lot of your bicarbs. I mean, you're retaining bicarb and losing a lot of your acids. Other conditions are also there, but just remember, when you get a problem, try to find the differential diagnosis. And once you know the differential diagnosis, you're okay. And then you can rule out based on your clinical judgment. Approach to metabolic alkalosis depends like this. What I will do the urinary chloride. And I will see how much is my urine chloride. It's very easy to be done. Even in your machines can be done. It's just your lab tech needs to know which machine they are going to use for the urine electrolytes. So urine chloride, if it's less than 20, it first means that this patient is hypovolemic in the context of metabolic alkalosis. And hypovolemia, which is fluid responsive, is due to vomiting, maybe RT aspiration. Do you know how many times the nurses are aspirating the contents of the gut and then throwing it away as well? This itself causes a lot of hypovolemia in the patient, in ICU patients. Diuretics, if it's a recent use, it can cause hypovolemia, and the urine chloride will be low. Okay? Urine chloride, when it's high, most of the times it means that there is no hypovolemia, and the patient will be having hypokalemia. These patients are usually fluid resistant. And there are two questions you're going to ask. Is my patient hypertensive or not? If the patient is not hypertensive, then current diuretic use could do this. Bater's syndrome and Gleiterman syndrome. We are not going to go into that, but you need to understand that this is how the algorithm works. Hypertension. If the patient is hypertensive, then look at their medication. Is the patient on diuretics, like thiazide diuretics? And if they are hypovolemic, then it means that, yeah, maybe this patient was using a thyroid diuretics and not drinking enough water, and that's why this happened. Mineralocorticoid excess, which happens when the patient is euvolemic. So nowadays we have the IVC. We can check easily, is the patient hypovolemic or euvolemic or hypervolemic. If the patient is euvolemic, the patient has hypokalemia, if the patient has metabolic alkalosis, and the patient is hypertensive, you can do renin and aldosterone, and you can find out the cause of the disease in this case. Now, before we go into metabolic acidosis, okay, I would like to bring up a case. Anytime you have acidosis, you need to calculate the anion gap. This is a case of an anion gap which is low. Okay? We'll come back to the case in a short period of time. Now, metabolic acidosis, again, is the same equation. When you have, okay, a patient, okay, which is producing things that are causing anaerobic respiration or producing acid in our body, all right, the pH will be low and the bicarb will also be low in this case, okay? So this patient has high amount of hydrogen in the body and they are losing bicarb in some way. So these are some of the equations that you can use. The one that I prefer, and it's because it gives you a better margin of error and it prevents you from overcorrecting your patient. And from personal experience, is 1 to to 1.5, it's a range, okay? It's a range, 1 to 1.5 is a range, times the change in bicarb. So for example, if you had a bicarb of 8, you do 24 minus bicarb, which is your ABG bicarb, which is 8, and that change times 1, and the change times 1.5, you get a range. And now the same concept is applied. If metabolic acidosis, I want to compensate by respiratory alkalosis, okay? So let's say my ABG, ABG has CO2 of how much? Probably it has 20, okay? And then I get a range. I get a range which is 10 to 15. So this means it's more than 15. That means there is metabolic acidosis and an additional respiratory acidosis. If it's below the range, then there is additional respiratory alkalosis. But if it's within the range, that means my patient is compensating. So first question to say is that, is the patient compensating or not? If it meets the range, then compensating. If it's off the range, uncompensated. Now how uncompensated? By respiratory acidosis, if it's outside the range on the upper limit, and if it's outside the range in the below limit, then there is additional respiratory alkalosis. And that's how you know metabolic acidosis. There is a trick for you guys if you are lazy and if you don't want to do these calculations. Just take the last 2 digits of the pH and compare it with your CO2. Are they matching? If they're matching, the patient is compensating. If they're not matching, then the patient is having an additional disorder. Okay? Whenever you have metabolic acidosis, like I said, you need to calculate the anion gap. The anion gap is simply the difference between positive ions and negative ions. And the difference should be between 8 to 12. That is a normal anion gap. Anything less than 8 is low anion gap, and anything more than 12, it's high anion gap, metabolic acidosis. So you get 3 types of anion gap: low, normal, and high. Now let's talk about that case that I was talking about. Look at this patient, has a pH of 7.39, which is quite normal, right? Because it fits the range of 7.35 to 7.45. Now we look at the bicarb. CO2 is low, but look at the bicarb, and it is 17.5. That means there is some sort of acidosis going on. Now we are going to calculate the anion gap. Now if you look at the anion gap, let me take out my calculator. So the anion gap is, we know that it's sodium, which is 133, minus, in brackets, okay, you have your chloride, which is 116, plus your bicarb, which is 17.5, and you have an anion gap of less than, it's a negative anion gap, it is 0.5. This is a curious case of low anion gap, which means there are 2 possibilities. Either this person has multiple myeloma, or the person has lithium toxicity. That's only when it happens. Now let's go back to our part of normal anion gap and high anion gap metabolic acidosis. Now on the right, you can see a high anion gap metabolic acidosis differential diagnosis. That can be anything. Now remember, whenever you have an abnormality, whether it's ECG, ABG, look at the abnormality, look at the differential diagnosis. What are my differential diagnoses? DKA, okay, ketones are positive. I have a high anion gap metabolic acidosis. Uremia, urea and creatinine are high. That's why I have a high anion gap metabolic acidosis. If I'm a septic patient, I have a high lactate. Urea creatinine is normal. That's why I have lactic acidosis. In normal anion gap, we know that it's between 8 to 12, and it could be secondary to GI losses like diarrhea. You're losing a lot of your bicarb. Moderate renal insufficiency sometimes can cause this. Renal tubular acidosis, which is a very important component, and we're going to talk about this just now, is basically very common in normal anion gap metabolic acidosis, and if you identify it, you might need to supplement this patient with bicarb. This is the only time you're going to give bicarb to these patients. And there are other causes as well. Okay? Now, whenever you have a high anion gap metabolic acidosis, okay, the anion gap needs to be corrected for albumin and for pH, and it's very simple. If you are acidotic, meaning pH is less than 7.35, you minus 12 from your anion gap. So if your anion gap was, ideal anion gap is 12, right? For every individual, you minus 12. So you minus 2, sorry. So 12 minus 2, that is now your ideal anion gap. Okay? Now if your albumin is deranged, meaning if your albumin is decreased by 1, you minus your anion gap by 2. Okay? If your albumin is increased by 1, you plus your anion gap by 2. So this is how it will happen. Let's say I have an albumin of 5, and you know normal is 4.4. Okay? So you take 5 minus 4.4, that you get a difference of how much? 0.6. Okay? So your albumin has risen by 0.6. So what do? You times by 2, and you plus that number to your anion gap. Similarly, if you have a low albumin, like let's say of 2, so you take 4.4 minus 2, you get a value. You times that by 2, and you minus that from your anion gap. That is your original anion gap. That's the ideal anion gap of that individual. Now, we have already talked about calculations of anion gap, which is sodium minus bracket chloride plus hydrogen, plus bicarbonates. And the value should be between 8 to 12. So what I'm trying to say is that sometimes you have calculated an anion gap, okay, which can be normal according to the range of 8 to 12. But when you do these corrections for albumin and pH, you realize that your anion gap is actually high and not normal as you think of it. So sometimes I can have a patient who has low albumin and low pH, okay. I corrected it, and my ideal anion gap is supposed to be 6. And when I calculated the anion gap from the electrolytes, I found out that it was 12, which is supposed to be normal, right? 8 to 12 is normal. But my ideal anion gap is how much? It's 5. So that means I have high anion gap metabolic acidosis. Okay? So now whenever you have high anion gap metabolic acidosis, you need to calculate either the delta gap, delta ratio, or the actual bicarb. I think the actual bicarb is very easy to calculate. You just take the change in anion gap, okay? So what is the normal of that patient, which I told you already you have to correct for albumin and pH. If you don't have albumin, if you don't have pH, if you don't have albumin, okay, remove that from the equation. But if you would always have the pH because you did an ABG, correct it for the pH, and then take the value that you got from your blood sample of the anion gap. Anion gap it's maybe 24, and I did 24 minus 10 because I have an acidotic patient. So 24 minus 10 is around 14, okay? Plus your bicarb, which is 8, for example. Okay, so 14 plus 8 is how much? It's 22. So anything between 22 to 26 means that this patient has a pure anion gap metabolic acidosis, and there is no additional or third disorder that you're thinking about. If it's less than 22, that means this patient has high anion gap metabolic acidosis plus your normal anion gap metabolic acidosis. And if it's more than 26, that means this patient has high anion gap metabolic acidosis with metabolic alkalosis. I'll give you an example how this is used practically. There is a patient with sepsis, so sepsis will give you high anion gap metabolic acidosis, right? Once you have that, you are now calculating your anion gap, which is 36, for example. And then, because you know that you have to calculate now the delta gap or delta ratio or actual bicarbonate, and we said I favor this. So you take the change in anion gap, which is 36 minus 10 because the patient is acidotic. Now you have 16, okay? Plus your bicarbonate, which was 10, for example. Now it's how much? 26. So if it's 22 to 26, it's pure anion gap metabolic acidosis. But what if your bicarb was maybe 15? Then the 15 plus your 16 would be more than 26. That means the patient has metabolic alkalosis. Now, why was it patient having metabolic alkalosis? Because the patient was being given furosemide. The kidneys had shut down. They did a furosemide challenge test, and that's why they gave furosemide. So furosemide caused metabolic alkalosis, and that's how you use it in real context in a patient with metabolic acidosis. Now, this is just for information as delta ratio as well. If you look at it, it's the same. You take the anion gap minus 12. 12 is the ideal one, okay? but you need to correct it for albumin and pH. Yeah? Minus 24, which is average bicarb, 24 minus the bicarb which you got, and you get a ratio. If it's less than 0.4, that means you have HAGMA, okay, which is, that means you have NAGMA, which is normal anion gap metabolic acidosis. If it's 0.4 to 0.8, then you have HAGMA plus NAGMA. If it's 1 to 2, then you have pure high anion gap metabolic acidosis. If it's more than 2, then you have metabolic acidosis with metabolic alkalosis. And some literature also says that you might also have respiratory acidosis in this case. Now these are the mnemonics that we use. Mud piles is a very common one, and it tells you that these are the causes of metabolic acidosis. Okay? This is a mnemonic called use parts. It's for non-anion gap metabolic acidosis. Now, for non-anion gap metabolic acidosis, okay, we're going to talk about it. You get a normal, which is 8 to 12, after which you have to further evaluate this patient. Many people forget this, and here I am to remind you. So first check the urinary gap. Remember that every institution can do this. They can check the urinary gap, okay, and it's very simple to do. You take the sodium plus your potassium minus chloride. Again, positive ions minus negative ions. If the gap is positive, then you know the problem is in the renals. Okay? If the gap is negative, then the problem is extrarenal. Once you know the gap is positive, right? If it's positive and the potassium is high of the serum, then this is renal tubular acidosis type 4. If the pH of the urine, if the potassium is normal now, you have to differentiate between RTA1 and RTA2, which is renal tubular acidosis 1 and 2. You differentiate by the pH. If the pH is more than 6, then that means that patient is having RTA1. If the pH is less than 5.5, then the patient is having RTA2. Okay? And this is how you know that this is a renal tubular acidosis and further differentiate into what type. Now here you can see that the patient has causes of non-ion gap metabolism. Now I'm going to show you how I can know that this is an extrarenal cause or not. So let's say if my gap is negative, then I will say maybe it's diarrhea. Maybe it's a pancreatic fistula. Maybe there is a small bowel fistula. Maybe I gave so much chlorides to the patient. Maybe normal saline. Maybe there was a diversion. Maybe this is Addison disease or acetozolamide. So majority of the causes are extrarenal. Only causes which are renal is RTA. Okay? So just remember that. Now, we need to understand something called osmolar gap. Okay? The osmolar gap is very simple as well. It's basically you take serum osmolarity. The serum osmolarity is 2 times the sodium plus your urea plus your glucose. Now, for those who are not using SI units, you need to divide urea, if it's in milligrams per deciliter, divide by 2.8. And if glucose is also in milligrams per deciliter, you have to divide by 18 to get it in millimoles per liter. You take 2 times sodium plus urea plus your glucose, and you get your serum osmolarity. Okay? Now your serum osmolarity, which is basically the one which is calculated and the one which you get from, let's say if you tell your lab to do serum osmolarity, and if the difference is more than 10, then that means high osmolar gap. Now it could be with NAGMA, meaning normal anion gap metabolic acidosis, or it could be with HAGMA. Now if it is with HAGMA, then you know there is a toxicology issues, and these are which you calculated, and the normal amount which the patient has, the normal that the patient has. And this can be identified by your lab as well. So let's say if I have high osmolar gap, but with normal anion gap metabolic acidosis, these are the differentials that you're going to look at. Okay? One of the common one is mannitol therapy, okay? Or ethanol immediately after toxic alcohol ingestion. If my patient has high osmolar gap with HAGMA, which is high anion gap metabolic acidosis, then again I have other issues that can be sorted here. It could be a toxicology cause, which is methanol, ethanol, diethanol, and so forth, or it could be endocrine or metabolic, which is lactic acidosis, decay, and acute kidney injury. Now, once you know about acid-base status, like metabolic acidosis, remember metabolic acidosis can come with other subsets. Like you have metabolic acidosis and hypokalemia. What are you thinking? You're thinking about RTA type 1 or 2, or you're thinking about decay, or you're thinking about excessive amount of adrenal infusion in shock patients, which can also cause metabolic acidosis with hypokalemia. You might have metabolic acidosis with hypokalemia in other causes as well. So it could be amphotericin B infusion, it could be lower GI causes like diarrhea, laxative abuse, fistulas, drains, and stomas. Now, how do you differentiate metabolic acidosis with hypokalemia? Just look at HAGMA with hypokalemia, that means decay and adrenal infusion. If it's NAGMA with hypokalemia, then you know about renal tubular acidosis, lower GI causes, and amphotericin B infusion. Metabolic acidosis with hypokalemia, these are some of the causes like renal failure, rhabdomyolysis, and salicylate poisoning, like aspirin poisoning, is one of the clues. Now, if you have metabolic acidosis with low or negative anion gap, the most common one is multiple myeloma, and second is lithium toxicity. Others are there as well, like bromide toxicity, hypermagnesemia, hypercalcemia, but these are rare, and the most common is multiple myeloma or a lithium toxicity patient. This is a summary chart of at least whatever we talked about in terms of metabolic acidosis. And this is how you would go about in a context, like the whole picture. You can screenshot this later, and we can even give you a PDF version of this. Now we talk about the last part, which is respiratory. Now in respiratory acidosis or alkalosis, you need to remember that the PCO2 is rising and the pH is either falling or increasing. If the pH is increasing and the PCO2 is falling, that is alkalosis. If the pH is low and the CO2 is high, that means it is acidosis. So the equation is like this. It's a box basically. And you can remember it like 1, 2, 4, 5. Okay? 1, 2, 4, 5. Okay? Remember the number 1 and 4 is for acidosis, and 2 and 5 is for alkalosis. Okay? Now I'll explain how. So every time you have a PCO2 in acidosis, it is rising by 10, right? So if it's rising by 10, right? If it's acute, then your bicarb should rise by 1. If it's chronic, it should rise by 4. If it's respiratory alkalosis, whereby the CO2 is decreasing by 10, then in respiratory acidosis, I said 2 and 5. Your bicarb is decreasing by 2, and if it's chronic, your bicarb is decreasing by 5. Let's just do one example, and I think you will understand the concept. So let's say you have respiratory acidosis, okay, whereby right now your respiratory acidosis is around 50. Now you want to know how much did it rise by. It would rise by how much? If the average of CO2 is 40, then 50 minus 40, it is 10. That it rise by how much? 10. And this was the acute cause. Acute cause meaning less than 24 hours. Chronic is more than 24 hours. Okay? So 50 minus 40 is 10. Now you take your cross multiplication. You do 10. A rise of 10 will increase the bicarb by 1. So 10 equals to 1. And right now also it rises by 10. So you have to say 10 equals to how much? So 10 times 1 divided by 10 is 1. So the bicarb rises by 1. So you do 24 plus 1. This will give you 25. This is the number that you need to compare with the number in the ABG. If the number in the ABG is showing bicarbonate of, let's say, 18, then this patient has respiratory acidosis and metabolic acidosis. Now, if let's say if the number was 25 in the ABG, that means properly compensating. I'll say if the number was 28, then it's more than 25. That means the patient has additional metabolic alkalosis. And that's how you go about respiratory acidosis. Now, alkalosis is the same. Now, alkalosis is decreased, right? And you know if the CO2 is decreasing, the bicarb is also supposed to decrease in order to compensate. So you minus the last equation, you minus by 24 rather than adding by 24. And that's simply how you do respiratory acidosis and alkalosis. These are some of the examples of respiratory alkalosis. It can be remembered by the mnemonic CHAMP. Okay? One of the examples is anxiety, hypoxia, and CNS diseases sometimes can do this. Acidosis, you remember the saint, and one of the commonest example is stroke or someone having respiratory muscle paralysis. They cannot breathe in and out, so they retain CO2, and that's how respiratory acidosis is one of the examples. Now, do we treat acidosis or do we treat the cause? We treat the cause, okay? Don't just give bicarb. Figure out what kind of acidosis do I have. Is it high anion gap? If it's high anion gap, treat the cause. If it's normal anion gap, and if it's extrarenal, treat the cause. If it's renal, that's renal tubular acidosis. This is where you can probably give bicarb because they have bicarbonate deficiency. So you have to look at the clinical presentation. You have to know you're reading the ABG, which is valid. Look at the oxygenation status, ventilation status, AA gradient, after which you go for your acid-base status. You look at your pH is low, and if your CO2 is high, that's opposite. If the pH is high, CO2 is low, that's opposite, means respiratory. If it's in the same direction, pH is low, bicarbonate is low, that's metabolic. Yeah? Metabolic acidosis, compensation is by the formula 1 to 1.5 times the change in bicarbonate. Okay? If it's metabolic alkalosis, 0.5 to 1 times the change in bicarbonate, and you can get your CO2 value. If you look at respiratory acidosis, the change in CO2 will determine how much bicarb will change in your patient. And then you plus or minus. If it's respiratory acidosis, you plus by 24. If it's respiratory alkalosis, you minus by 24, the final value. And that's how you sort out your ABG. Now let's do some examples and then we call it a day. Case number 1, a pH of 7.29, okay? And CO2 is 68. Your bicarb is 26 and your base excess is negative. What is the problem here? So you know pH is low, CO2 is high, and bicarb is like near normal, 22 to 26, right? So here the problem is what? The problem is respiratory, okay? Because pH is low and CO2 is high. Now you're going to do all those formulas to find out if they're compensating or not. Let's do one. 68 minus 40, you get a number, right? So 68 minus 40 is what? It's 2 and 8, right? So it has rise by 28 millimeters of mercury. Now you know if this was an acute case, then if my CO2 is rising by 10, my bicarb should rise by 1. So 28 is what it has rise in this patient. So how much bicarb should be rise? So let's make it easy. It's 20, for example. 20 times 1 divided by 10 is 2. So your bicarb rise by 2. So you take 24 plus 2, which is 26. Now, is this matching? Yes. So this person is compensating. Now let's go for the second one. pH is 7.49, which is more than 7.45, which is high. CO2 is low, and bicarb is also low. So here there are two disorders. The primary one is respiratory alkalosis, but you also have respiratory metabolic acidosis in the mix. Now again you are going to do the same thing. 40 minus 24, okay, let's say 20. 40 minus 20 is 20, so it has fallen by 20. So if 10 equals to 2, because it's respiratory alkalosis and it's an acute case, so 10 equals to 2, then 20 equals to how much? So 20 times 2 is 40, divided by 10 is 4. Okay, so your bicarb should decrease by 4 in order to compensate. So take 24 minus 4, which is 20. In this case, this patient has 22. It is less. Your bicarb of what it's supposed to be, it is more than that. So there is additional metabolic alkalosis in this patient. Okay? So this is how you do your respiratory cases. Okay? Now you guys tell me about these cases and answer in the comment section below, and I'll give you the correct answer in less than 24 hours. So that's all from me. I know it was exhausting for you, and this is a lot to capture. What happened here? Why did it turn off? Okay. Even though it was an exhaustive talk, but I believe that your eye has opened now, and you will take ABG in a different light. You will take it seriously. You will make sure that everything is as per systematic way. And the systematic way is the right way. So don't try to do shortcuts. Don't just end up at saying that, oh, this is respiratory acidosis, fine, but try to find the compensation. If it's metabolic acidosis, try to find the compensation. And that is very important in any of the ABG interpretations.